Hi everyone. So it was great. It's great to be here, and congratulations, Robin and everyone, for sort of lobbying for the importance of Tourette. This is a common condition that is relatively under-recognised in the community and doesn't have high enough priority, in the same way that autism, which is another condition that I think is very important, but has relatively low priority given how important it is. So I think we can all influence that by coming together, joining hands and sort of talking about it, and all of these initiatives are fantastic. So look, I'm a neurologist, but I'm also a human being, and I'm a parent, and I know, and I learn constantly from my patients. So the lessons that I learn, and every year I understand a bit more about this condition, but there's loads I still don't know. And as a neurologist, I've come to terms with that. The brain is so complicated that we've got loads of things to learn.
Wow.
So this is what I'm going to talk about. I'm going to talk about, it's a bit medical, but I realise this is a very informed audience. So I'm going to talk a bit about etiology, meaning the cause. I'm going to talk about comorbidity, which Adam touched on very, very well. And I thought it was wonderful that he gave his list, but then he gave his priority list. And I think that is a key thing in the treatment of Tourette. And it was just like priceless. He sort of nailed it. And to be honest, I can just leave now. And then I'm going to talk about treatment, acknowledging, and again, as many of you already know, that medicine is not the answer. It's a requirement in some, but certainly not the answer. And really, education, acceptance, and understanding is core business. Number one, again, as Adam said, his talk would have been superb at any conference. So we've known about this for a long time, this condition we call Tourette syndrome. The complete name is Gilles de la Tourette. He was a Frenchman, he was a French neurologist. But he described it a long time ago, but we really haven't understood it, that this is actually a brain, these are brain symptoms, until much more recently, in the last 30 or 40 years. And this is how we diagnose it. Ticks are very common. So ticks, isolated ticks or transient ticks, they occur about in 1 in every 6 boys. So that's extremely common. But if you have motor, and so a boy or a girl, but particularly boys, may sort of transiently blink excessively for a month or two, and then it just goes away. And that's not Tourette syndrome, but that is a tic disorder. And so this continuum between tic disorders and Tourette. We use the word Tourette when you have motor and vocal tics for more than 12 months. That sounds a little arbitrary, and it is a bit arbitrary, because if it's only 2 months, it's a tic disorder, but if it's 12 months, it's Tourette. That sounds a bit unnecessary and arbitrary, but it's sort of useful, because if the tics last for 12 months, they're probably going to last for longer, some years. So that's why it is a sort of useful demarcation. So what do we know? We know it affects up to 1%. Most people agree it's about 1 in 200. About 1 in 200 to 1 in 100, which is 0.5 to 1% of school children. So that's pretty common. That's more common than epilepsy, it's more common than diabetes. But those are much better known in the community and much higher priority in the community. So again, we can do something about that maybe. Lobbying, as you are, with Greg Hung, this is all good. It's getting this condition in the minds of people of influence, should we say, and who hold budgets. So, and it's more frequent in boys, probably about 3 to 1, and it's more common in people who have other neurodevelopmental disorders. And Tourette is a sort of neurodevelopmental disorder. What does that mean? Neuro means brain, development means sort of part of developmental trajectories. So it sounds a fancy name, but it's not really. So, what are tics? So they're usually fast, they're usually sudden, and they are always repetitive. So you have the same kind of movement or same kind of noise. And this word is stereotypical, meaning same. So, you know, blink,
Put the kettle on, grommet.
it's sort of the same. What we know though, ticks do move. So you can, even the same individual from day to day, week to week, month to month.
I'm a what?
And this is a very interesting thing, that they're partly involuntary. And you know, as you know, you guys who have ticks know this very well, that you're able to suppress to some degree, for some duration, and partly dependent on what you're doing. You know, and you know, Adam when he's singing, and you know, I'll talk about another guy. You know, and some people when they're playing the guitar or doing some activity, the ticks are often less, whereas at other periods and in periods of stress, they tend to be elevated. So there's this sort of unusual suppressibility, but there's also this feeling. Tics are not just a movement or a noise, there's sort of a feeling or an urge. And so it's like this feeling and an urge and a movement or a noise, and then it's like this little loop back and forth.
Fucking fantastic. Beaky boy. Cockberry. Cockberry.
So this is a sort of family video. The audio is not necessary, but and you can see this young boy has tic disorder, and it was sort of this school performance that made the family sort of acknowledge that there are excessive movements. You know, when you see the repetitive, there's mouth opening and the head flexion movement. So a couple of sort of repetitive, stereotypical movements. And these would be fairly typical motor tics. And the most common tics are sort of shoulders, head, neck, face. But they can be anywhere. They can be arms, legs, spinning, jumping, hopping, touching.
Got him.
So some people describe this sort of feeling or urge, and some people describe it like an itch. And I mean, you know, the people with tics in the audience would describe this much better than me. But these are some of the things that are described. It's like a feeling or an urge to tick. But what we recognise is probably this is only actually described by individuals as they get older. That may not be that it's not there, it's just that it may not be acknowledged or recognised by the individual. Like everything, we have this sort of spectrum from the more simple motor tics, such as blinking, to the much more complex ones, you know, including sort of actions or spinning, jumping, hopping, touching. Likewise, vocal tics, probably the most common one is throat clearing, but squeaking, parts of words, bits of words, and of course, sort of sentences as well.
Sandwich.
So this is a young man from Victoria who has complex motor tics. He can't sit down, but he has this sort of hopping and this sort of walking. He has a twisting movement with his legs. That is a tic, that is a tic. All of these sort of things are tics. He has a blend of Tourette and OCD, so some of them are sort of a bit compulsive. And this overlap between tics and compulsions is a very challenging area diagnostically, both for clinicians and maybe for the patients too. And it's not unusual for us to agonise about it, not always coming to conclusions. So usually tics appear in this sort of young age, sort of between 2 and 10. So when they appear up here, that's a little unusual, and it makes you ask the question, you know, is this a typical tic disorder? So it's much more normal for them to appear in that sort of early school age kind of period. We have an ability to measure tics. You know, we can measure the number, the severity, and the impact. I must say, usually the family and the child tell you whether, you know, how much of a problem it is. You don't really need a fancy test to be informed, because the patient sort of talks. And I'll talk about in a minute, the decision to treat is all about function. So how much are the tics, how much of the comorbidity affecting the function of the individual in day-to-day living. And as Adam showed very nicely, this isn't just a tic disorder. In about 85% there will be other symptoms. And the most common ones are attention deficit disorder and obsessive compulsive disorder. And then other emotional symptoms and other symptoms as well, including sensory symptoms that I mentioned. But other echo phenomena, that means sort of echoing things, and also pally phenomena, which means repeating things, so a predisposition to echoing, repeating. And then some of the fame, of course, of Tourette is this cockcrow stuff, which is the swearing stuff. But actually, it's often not a big deal. The majority of patients is actually not present. But when it is present, it can be a problem.
Real late at night time, cocker spaniel.
And what we typically see with the ticks, they start in early childhood and they usually get bigger and more common, and then they usually decline. And so what we talk about in clinic, and this is a real thing, is that usually the peak of ticks are between 10 and 12. And then usually between 12 and 20 they improve to a degree. And so in some people they improve a lot, and I'll show you a video to show this in reality. In some people they improve a bit, and then in some people they don't improve that much. But it is lots of room for optimism that 10 to 12 is usually the peak, and 12 to 20 and beyond is improvement. And attention deficit disorder, if it's present, it's almost always present before the tics. The symptoms are there early. So ADHD doesn't appear when you're 10. ADHD is usually there from an early onset. Obsessive compulsive disorder usually appears a little later. And so this is really what we deal with. Yes, Tourette's is here, but there's lots of little overlapping things, and these are all sort of brain-related symptoms. And some people are here with tics and ADHD, some people are tics and OCD, and some people have, a collection of lots of things. And yes, there are some people who just have tics. But actually, Adam said 86% of people are here. And yeah, he's absolutely right. So what's the cause? I get asked this, probably once a week. The truth is I usually give pretty rubbish answers because we don't have really the full answers. I think we know some things. We know this is a brain thing. What I think about Tourette's is as though the ability to regulate the brain or control the brain, and there's just too many movements, too many worry thoughts, too many, the ability to control or regulate movements, regulate emotions, and regulate attention. So this is a sort of problem of regulation. But there's some things we definitely know, and it's not the child's fault, and this is part of the education, it's not anyone's fault here, this is a sort of brain condition, but it's not progressive, it's not degenerative, and what we know is typically they improve between 12 and 20. And it's often considered to be called a neurodevelopmental condition, as I told you. So doing brain scans is not a useful test because the brain scan will be normal. The structure of the brain is normal, so really tests are not part of the diagnosis. The diagnosis is based on observation and history, and so you don't really need to do any tests. But it seems there are subtle changes in the brain when people have done research in this area, but the brain test, and people often talk about the basal ganglia. The basal ganglia is this sort of control center in the middle. And the way to think about this is that there are lots of sort of circuits in the brain. If you think of the outside of the brain, there's lots of these thoughts and circuits going between the outside of the brain called the cortex and the inside of the brain, which is where the basal ganglia are. And there's lots of these circuits going back and forth. And some of these circuits are activating, so switching on thoughts, and some of these circuits are sort of calming things down, so inhibiting. And a lot of the thought is that there's this mismatch between exciting and inhibiting. And that sort of resonates a little bit with, the patients. It's as though the sort of control valve is a little bit sort of off. And so people often talk about it in those terms. And then people like to talk about chemistry, they try to medicalize it, so, oh yes, it must be the dopamine, and it must be the... Truth is, we don't really know, but we can talk about it and pretend we know. But the things like GABA and choline and histamine and dopamine, and yeah, probably a bit, but it's much more complicated than that. I think it's pretty obvious genetics are important, and it's very pleasing to know that there's Australian genetic research going on in this area, and you know, very important. There's no doubt genes are important, but genes are not just the answer. That's also clear as well. So, you know, this is a typical family history. This square represents boy, circle girl, a boy with Tourette and OCD, a sister who is well and has neither, a mum who has no tics, OCD, and dad who has tics in childhood and some OCD in adulthood. This is a fairly classic sort of history, but I can tell you it's not always like that, because it's often a bit like this, where you've got a boy who's got Tourette's and ADHD and a girl who's well, but mum and dad don't seem to have any, you know? So there you go. Just shows that every patient and every family is a little bit different. Different in comorbidity, different in family history. And so people have tried hard already in the genetic stuff. Don't think they haven't tried before. People have been trying for about 30 years and probably spent tens, maybe hundreds of millions of dollars, particularly in America and Europe, trying to unpick this. And in truth, it's been a bit disappointing. And yes, there are some, what we call vulnerability genes, is a better way of looking at it. This is not like if you have this gene, you're going to get this disorder, nothing like that. If you've got this gene, it may predispose you to being a bit obsessive or a bit ticky. That's really the way we look at it now. To give you a level of the complexity, just so you realise that really doing a gene test is not going to answer your specific situation. That's why you have to do it in research and cohort terms. A recent paper suggested that there are about 400 genes that may explain about 12% of Tourette syndrome patients. That's pretty complicated. You know, so on an individual level, it's going to be hard. This is something we're interested in research, and some of you have been helping with this. We recognise, or we seem to think, that there's other roles. It's not just genetic roles, there may be environmental roles, and some of those environmental factors may be immunological. And what we've noticed is we get this kind of family history where the boy has autistic spectrum disorder and Tourette and OCD, the girl has Tourette and OCD. Both parents have no Tourette's or OCD, but mum has an autoimmune disorder. Mum has autoimmune thyroid disease, Hashimoto thyroiditis. We seem to see a lot of this, I don't know, and so we're doing some research. And actually, interestingly, there was a very big study in Denmark in a million children, and they showed that this was an epidemiological study, which means population study. And they showed that a maternal history of autoimmune disease increases the chance of the offspring having Tourette, which is a little bit of a curveball there. But it just says that this isn't all about just simple genetics. And we're interested in this idea that if a mother has an immune disorder and while pregnant, it may affect development of the brain and sort of increase the expression of vulnerability genes. So what we're doing with Hannah Jones, who's a neurologist like me, we're doing a detailed family history of 200 patients with Tourette to work out how common autoimmune diseases are in not only mum and dad, but siblings and second-degree family members, and comparing them with other control groups. So I'm going to talk about treatment. And with treatment, the starting point is always this, because there's no doubt every child and every family is different. Different in comorbidity, different in severity, different in coping strategies, different in social networks. And so these are the questions. How much are the tics or the comorbidity affecting the quality of life, happiness, causing distress, affecting friendships, affecting family life, social life, and self-esteem? All of these things are possible, but in some, you know, I sometimes ask 8-year-old boys who are having a lot of tics, you know, how much do the tics bother you? And the boy just, not really. You know, their friends don't care, they don't really care. The parents are concerned, understandably, but actually the child is not that bothered. Now, when you become 10 or 11 or 12, you know, and self-esteem, and, you know, life changes. Life becomes more complicated. And this, as Adam said, this is sort of absolutely spot on. The beginning point is all about education, understanding, and acceptance.
Got him.
So we have to sort of, this is what it is. This is what Tourette is. Yes, it's a brain symptom.
Got him.
It's not their fault.
Control my
They can't
bum.
help it. They're extra movements you can't control, although they are
I don't know, I
suppressible.
just can't
And that suppressibility is such an important symptom. I can't tell you how many families report the same sort of thing. That the child spends an enormous amount of energy suppressing during the daytime, and then they get in the car. It's because a lot of mental energy, which probably is tiring. Again, I can't say it, but this is what people tell me. And, suppressing at school, and so by the end of the day, sort of worn out. And so out they come. And actually that sort of explosion is probably therapeutic. It just sort of has to happen. So some kids, you just got to get them in the garden and get them to move about and sort of, just get some of that energy out. And so education is very important. The websites, as we've already heard, and good resources like the Tourette Syndrome Association websites. And then education and empowerment. So we've got some role models that we've heard from today. The three guys who spoke, they're role models. They're advocating and they're educating. So this is very important. I will now talk more about Adam in my clinic and James, but I often talk about this guy. So I'm English as my accent may declare. So I love sort of soccer. I grew up with this. This guy has Tourette syndrome. His name's Tim Howard. He has Tourette syndrome and OCD. Now he is a goalkeeper. He was a goalkeeper for Everton. He's now retired. And the United States international team. That's a pretty high bar. Yeah. So in other words, he did the very highest level in his field. And as Adam said this very clearly, hopefully this will not hold you back and you will achieve what you want in life. And that's such an important message. And he's got his own blog and he's got his own website. This is an odd slide, but I have one of my closest friends in the UK, a good friend of his has quite significant Tourette. And as an adult, and he flies fighter jet planes for the British Navy. And when I sort of meet him, I go, oh, you sleep. I suppose we have $200 million airplanes, but anyway, he hasn't crashed that. But so the point, and this is sort of a good example. It's again, sometimes families ask me, can they drive? Can they drive? And I say, yeah. Because people with Tourette's don't crash. In fact, your ADHD is probably more likely to get you in trouble than your tics, because of attention and impulses, again, as Adam said. But actually tics themselves, because what happens when you're driving, and correct me if I'm wrong, but this is what people tell me, is that when you need to concentrate, you're there and you're concentrating. And when the coast is clear and things look more relaxing, you do a few tics, and so actually you can sort of manage that quite well. So I had the fortune of this guy. He's 18. He rang me about a few months ago and we spoke. And basically, he wanted to tell me about the fact he's got Tourette syndrome, and when he plays the guitar and when he sings, no tics. And he's used this therapeutically, to help him through life. But also, and so I said, oh, why don't you send me some audio, and I can listen to your music. And anyway, he sent me this amazing video, and it's just awesome. And maybe not quite sort of Adam's level, but this guy's a very good amateur. Okay, so again, it was wonderful to sort of hear his story, and also what his strategies that he had learnt. Look, it would be better to listen to a lot of his song rather than listen to me, but so these are the stories that I think are very important. So education, tics don't damage the brain, they peak between 10 and 12, they then improve in most people. So in about 90% of tics have improved. Oh, the other thing I didn't talk about there was the house thing. Is I work with doctors who have tics and obsessive compulsive disorder. You know, again, just giving this example. In fact, a little bit of obsessive compulsiveness is useful, and in fact, quite a lot of neurologists have a little bit of obsessive compulsiveness. But the disorder is, you know, OCD is different. You know, being a bit obsessive is okay, but when it crosses that line that it stops you leaving the house or, you know, performing tasks, that's a big problem. So this trajectory is very important. So this is a young man who had, this is him when he was 10, and you can hopefully, you appreciate that? He has lots of little tics, blinking, mouth opening, tongue protrusion, shoulder movements, head movements.
Cocker. Got him. No, cocker.
So he has sort of lots of simple motor and vocal tics. This is when he was 10.
Got him.
And the point for showing this video is this is him when he's 14.
Got him.
And I think you can appreciate, yes, there's still some tics there, but they're significantly reduced in frequency, severity, and noticeability. So he, like many people, has sort of reduced in this time span. You can appreciate that the amount of tics he has is a lot less. So this is again very important for families to be optimistic. As I say, it doesn't always happen that way. So what about treatment decisions? So it's all about defining how much of a problem this is. What is the impairment? And I think, you know, I realise the limitation of our interventions. And so understanding and acceptance is very, very important. And so in the patients I see, and we see about 3 new patients a week, so that's quite a lot, you know, this is again not a rare condition. So for about 70% we don't do any sort of therapeutic intervention. And it's really about education, understanding and acceptance. And that alone, don't underestimate the importance and how therapeutic that can be. Once you know what it is, you say, okay, I get what it is, and then I accept, and then the environment understands and is educated. So family members, teachers, friends, as necessary. There is this, it sort of takes the heat out of the situation, and things will actually naturally improve. And so, you know, everything you guys are doing, and the education, the support, that is therapeutic. We see this the whole time. You know, I refer patients to my psychology colleague, and they usually say that by the time they see, you know, just having been seen, things are 30% better, because it just takes some heat. You're not on your own, you're not alone. We understand what this is, and that is therapeutic. But in 30%, you know, we don't underestimate the fact that this is potentially impairing on function, education, friendship, happiness, family life. And our interventions can be psychological, behavioural, sensory, medical, or that says alternative. And alternative, I'm very, very respectful of, because what we do is not very clever and is not very sophisticated, and it does not address everything. And so when people come and say I'm taking magnesium, or I'm doing herbals, or I'm doing homeopathy, I say, right, what is it? You know, tell me, and you know, is it helping? Because I actually think there's a lot to be said for this whole area. So what was this was a very interesting publication in 2010, and it showed that a behavioural intervention could help tics. And this sounds like we should know that, but actually before this time we didn't really. So this was definitely a landmark paper, and it shows that a behavioural intervention can help tics. And what it does is it aims to create a competing response. It's not magic, it's not amazing, but it does sort of help. The problem with this is the individual needs to be motivated. They need to understand their urge. And it's probably better if they have 1 or 2 main tics. You know, it's hard to combat a whole array of motor and vocal tics. So they need to be insightful, aware of the urge, and motivated. So yes, it is therapeutically valuable. And the other thing is you need a trained psychologist. And in truth, and Jenny would probably agree, there are some outstanding psychologists who get Tourette's and who get OCD and who get autism. But sadly, there's not many of them. And they're a little thin on the ground, given the fact we're talking about 1 to 5% of the child population with some of those, with OCD, Tourette's, or autism. We definitely don't have enough good psychologists out there. And there are some excellent ones, and they're fully booked. So maybe Jenny can talk about that more later. So medicine, as I said, is not the answer, but it does work in some. And so, this is all about, in the most impairing individuals, where the child and family have come to the conclusion that they need sort of some help medically. This is sort of what we generally do. So clonidine or catapress is often the first line. There's a new medicine called, which is guanfacine, which is Interniv, that some of you may have heard about. It's generally recommended in the first line. And it has been, an RCT means a randomized controlled trial. And there is the highest level evidence to show that this does work. Okay, so that means a blinded control group. That means people didn't know whether they were on treatment or not on treatment. And so it was conducted at the very highest level of quality. And it showed that it works. So there are many things that people try things, homeopathy, and some of the things I try are not actually evidence-based. But this is evidence-based. That doesn't mean it will help that individual. So you have to know that it will only help a bit, and it may help you, it may not. So it's a little bit frustrating. And you also need to know that have an expectation that is realistic. As Adam said, there is no cure, there is no magic medicine. If there was a magic medicine, you wouldn't be sitting here. Okay? Because unfortunately there isn't. But it does help a bit. And if that 30% can be useful, if you turn an impairing tic into a less impairing tic, that can be useful. Now this is the second line that we turn to, the antipsychotics. And yes, these are bigger drugs. Definitely. I prescribe these in about 5 to 10%. That's all. So, if the problem is very significant, particularly if there are severe tics, plus behavioural problems, mood disorder, then sometimes you have to use these kind of medicines, okay? So it's unusual to just treat the tics with these, but if you have lots of comorbidity, this can be useful and it can be transformative. So yes, it's a big drug, but it's sometimes needed, and that's all I would say to you. But this is a contract to people like me with the child and the family. If I say I think you should take this, and the family say I don't want it, well, that's the end of that. So this is a contract. It's teamwork. You have to agree that you have got to this point and you need to try this. But they are associated with side effects. It's not for the light-hearted. The most common one by far is weight gain and appetite increase, which can be a big problem. Although this one is much better than that one for this. So Abilify or aripiprazole is called weight neutral, which is probably pharmaceutical language, but it's better than risperidone. So, but you need to understand, it may help the tics a bit, this kind of area, but it is variable between individuals. Now, other medicines, to be honest, the other medicines are not so good. These are other medicines that you could use. This one you're going to hear about later. I get asked about this in clinic about once a week. What about cannabis? What about cannabinoids? The truth is, it's interesting. This is another drug that works on the brain, just like the other drugs that works on the brain. Just because it's natural doesn't mean it's any better or safer. And I'm an authorized prescriber for this in epilepsy, and so I get sent all the side effects from the drug company. Liver dysfunction, sedation, so it's not a bed of roses, okay? It's another drug with another group of side effects. But I think it will be useful, and I think it is interesting. But we need to have some decent evidence, and we need to understand safety in children, okay? Because we all know that, it's not 100% safe, is it? And then this is interesting, Botox, if you have a very severe whiplash tic, I've used Botox here, and it interrupts that sort of, that nasty tic that's causing a lot of pain. I've used it twice, so, pretty rare. And then deep brain stimulation, One patient I've seen, I must have seen about 1,000 patients in the last 10 years, and we've done one deep brain stimulation. So I'm not really going to talk about it.
Lesbian.
And then other approaches, these are really important. You know, mindfulness, coping strategies, anxiety management, taking care of yourself, being physically fit. Physical fitness is important for mental fitness. There's no doubt. We know all this. You know, so yoga, massage, relaxation. These are therapeutic. This is all part of keeping yourself well. I'm going to talk about this in a minute. And then, you know, some people have tried dietary things, herbal things, and, you know, I am respectful of different possibilities because I think it's good to think laterally and outside the box. But I always make sure the families aren't spending too much money going down a rabbit hole that may be based on flimsy stuff. So by all means, as long as it's safe, think about safety. If you can do this stuff, make sure it's safe and don't bankrupt yourself in the process. So what do? No treatment in majority, acceptance, understanding and education, clonidine or behavioural strategies, and then if needed, you go to the stronger stuff. But as Adam made the outstanding point, usually I'm spending more time worrying about these things than the tics. So what I usually do is I try to take a history for ADHD, obsessive compulsive disorder and anxiety and mood disorders and sensory symptoms. Because often they're more annoying and they're interrupting happiness and function at a much higher level than the tics. So they're often more of a problem. And also they may be driving the tics. So some of the kids with ADHD, if you treat the ADHD, sometimes the tics improve. Certainly the emotional control stuff, the child with the emotional regulation problems, you treat the emotional symptoms psychologically or medically, and it can bring the tics down. It's not always that way, but it's often that way. And so the other good thing is the comorbidity is actually sometimes more treatable than the tics.
How exactly did that connected?
So I think OCD and tics are biologically connected. You know, so people think that actually the genes in the other brain, if you like, symptoms, they have a sort of overlap. Even though OCD and tics seem different, but they seem to be biologically connected. Likewise with ADHD, but the relationship's a little weaker. But you know, it's a great question, and lots of people are trying to answer that good question. So treating the comorbidity. So this is often the priority. And actually in our clinics, we often spend more time talking about ADHD, anxiety, OCD, and emotional regulation symptoms. When I say emotional regulation symptoms, what I'm talking about is that sort of volatile emotional stuff that is very common in Tourette's. It's that sort of small thing, big reaction stuff. You know, people don't name it very well. And I like emotion regulation. It sort of sounds about right as a word, but we're talking about anxiety, we're talking about OCD and mood. So what is OCD? Well, first of all, OCD is an anxiety disorder. It's an emotional disorder. And obsessions are the thoughts. Think about these are the thoughts that get stuck. Okay? So we all have thoughts that are sort of worry thoughts. Oh, I forgot to lock the house. Okay? No, I did lock the house. Okay, I'll keep going down the street. Okay? But the problem with OCD is that thought gets stuck. And so I didn't lock the house, I've got to go back and check. And you go back, check the door, and then you do the same thing again. I didn't lock the house, I don't think I locked the house. And so that is a symptom, the obsession is the thought, the compulsion is the check. Okay? So the obsessions are the thoughts, the compulsions are the actions. So obsessions are repetitive thoughts, sort of worry thoughts, sometimes about safety of people, sometimes numbers, contamination, lots of different types. And the compulsions are the repetitive actions in response to the thoughts. And so the more common OCD symptoms in people with Tourette are compulsive touching and tapping, rubbing, sometimes some violent or aggressive thoughts, sometimes religious or sexual themes, and often symmetry. There's sort of left-right, and there's often a just rightness to it. You know, and that word just right is sort of important, and it's connected with OCD. It needs to be just right. You know, perfectionism, correct, has to be done, has to be finished, has to be just right. So checking, counting, ordering, hoarding. Now OCD, so with tics it's easy to, because you see them. The problem with OCD is if you don't ask the questions, you don't make the diagnosis. Okay, because there's no visible, unless they're sort of left, right, check, tap, tap, which sometimes is the case, but it's a bit of a sort of silent disease. And in fact, it's not unusual for you to make a diagnosis of OCD in a parent when you see a car with Tourette. When they sort of quite goes, oh well, I do that, and I've always done that all my life, and I also do that, and I've done that, but I've just incorporated it in my life. And that could be obsessive compulsive behaviour. It becomes a disorder when it impairs function. So if you just check the door, you know, and you're very exact and you're very precise and you're very home proud, that's probably obsessive compulsive behaviour. It becomes a disorder when it affects your happiness, function, etc. So here's a couple of videos. So this is a young lady who's now 20, and we don't see her anymore. She lives down in Victoria. But she has Tourette and OCD, and she's just describing her OCD to us. She's an incredibly empowered young lady, incredibly impressive. I'm absolutely convinced she will be a CEO of a company. Because every time she used to leave clinic, I said, oh, she was impressive. She used to tell us what to do, which I'm very happy with that. Can you hear this? Or just
Spaniel.
I think it's more there.
Face boost.
How do we go up now?
Why is breathing like a riding desk?
That's the best you're going to get.
Alright, we'll abandon that one. So she's just telling us about every time she sits down to do work, she has a sort of routine that has to go to, everything has to be in exactly the right place and has to be done sort of perfectly. So here's a couple of other videos. There's a young man who has tics and OCD, and this is an example of how you know those are tics, and then there's this touching. There's a left-right thing. I'm not sure what he's doing with the umbrella, but anyway, the umbrella. We lose the umbrella in a minute. I don't think so actually. But anyway, so there's left-right, and it's sort of touching. And I think there's a bit of a just rightness to it. So this is an example of how tics and OCD sort of hold hands together. And I think he does another left, there you go. So this is left, right, and there's a sort of feeling to it. It needs to feel right or
Got it. Bullseye. Bullseye. Got it.
And
Reach for the sky.
this young man had again tics and OCD. But he used to have a sort of hitting tic, but it wasn't just a hitting, but the hitting had to be just right, and he made himself bald here, because essentially he had to hit it in the right place, at the right feeling, to stop. So, you know, that was a pretty annoying and intrusive tic, obviously. So this is, again, how tics and OCD have this sort of holding hand relationship. Sometimes it's easy to say, yes, that's a compulsion, that's a tic, but then you sometimes have these more complex tics, particularly touching or evening up or left-right. And it is important because the treatment differs. So a tic has an urge, whereas a compulsion usually has a thought, which is a worry thought. That's the way to try to pull them apart. It's not always that easy. So what about therapeutically? The first line treatment of OCD is psychological. And really, it's always very important to try to, if you've got OCD or anxiety or emotional disorders, psychology must be the first line therapy. And this is a combination of, again, psychoeducation and understanding, and then this exposure response therapy that I won't talk about in any detail. But essentially, these are proven therapies. And just like RCTs, the randomized control trial, the evidence proves that these work. And the other thing you can do is there's lots of good books that you may learn about OCD, and we're not short of them out there. I don't know what you think is the best one. The other thing, they all have value. The other thing I sometimes say is that there's some beautiful research showing that cognitive behavioral therapy, so psychological therapies, change the way the brain works. And that using these fancy, what's called PET, or functional imaging, they can show the way the blood flows differently to different parts of the brain. So it just shows the power of psychological therapy to help the brain work differently. Now, it takes time, you have to commit to these therapies, but psychological therapies are very important for OCD. And I work with Chris Hardwick, who's a psychologist at Children's Westmead, and I don't think I could work in isolation. I can do the diagnostic stuff, I can do some medical stuff, but we need Chris, and we also work with Nikki, who's an occupational therapist, and we sort of think, Tourette's is a beautiful example of it's not just a brain condition, it's not just neurology, it's not just psychiatry, it's a bit of psychology, psychiatry, neurology, but it's also a bit of a humanity kind of thing. This is much more complex. It's about families, it's about coping, it's about
Got him.
and so if the psychological therapies are inadequate, the SSRIs, which are Lovan, Luvox, they do work. You only use them in the case where the OCD is a big problem, and the psychological therapies are not enough. Sometimes you just simply have to use these. Some of the patients I see, the OCD is so bad, they literally get stuck walking like this. And when a child has OCD that they can't get out of the house because they're stuck because of intrusive thoughts, that is a big problem. OCD is a common disease, and it's a potentially impairing condition. Thankfully, most people who have OCD don't have it that bad. But we have to respect the fact that sometimes you need to use the meds. The good news is most people who take these drugs, the SSRIs, of all the drugs I prescribe, I prefer prescribing these, which is bizarre for a neurologist to say that. But it's because they're usually well tolerated and they definitely work. But I always say that 1 in 20 patients, it doesn't suit them at all, and they will become agitated and miserable. So like all drugs, this is a drug, it acts on the brain, you only use them if you have to, but when you use them, they do have a role. And then ADHD, of course, is very important. These are the core symptoms: reduced attention, poor concentration, fidgety, overactive, impulsive, and intrusive on adult conversations. And usually the school report says those words. So if you want to make a diagnosis, you go, can you show me the school report? And you go, oh, Johnny is a delightful boy who could do better if he could maintain attention, had better concentration, he's prone to getting out of his chair constantly, he's a bit impulsive and sort of acts before he thinks, and he tends to intrude and sort of not wait his turn and he shouts out as we do. So, the school are part of the diagnosis, as well as obviously the family. Again, this is a very important diagnosis to make because it's treatable and it does impair function. Now, having a bit of ADHD can make you sort of, pretty fun, and you take a few risks and you can have a good fun life. Some people who don't like having their ADHD treated because you lose a bit of edge, maybe. But sometimes when you've got significant ADHD, this is your educational ability, but this is your educational performance. Okay, that is the tragedy of ADHD. Okay, so if your ADHD is inhibiting your ability to do schoolwork, that means your ability to get grades, that means your ability to get employment, that means your etc. So ADHD is an important condition.
Boy. I'm in my mum's car. Got him.
Okay, we've already done that, so I think I've already touched that. So what about management of ADHD? Well, again, understanding and acceptance and accommodation, as Adam said, and then if needed, and again, this isn't for everyone, the stimulants, so Ritalin, dexamphetamine, atomoxetine, or clonidine. Now, this remains a problem. The stimulants in Tourette, if you read the back of the packets, it still says don't use in people with Tourette syndrome. But actually, there's been 2 randomized controlled trials that have shown that the stimulants help ADHD in people with Tourette's, and they're tolerable. That doesn't mean that every patient will benefit from them, and that doesn't mean that every patient will tolerate them. And I always tell the families that side effects include appetite suppression, change in mood, change in personality, and can make the tics worse. And that does happen, but in many that doesn't happen. And sometimes when you try them and it's successful, the families come back and the child comes back smiling. And they look you in the eye and they say, this is the best thing we've done.
Got him.
That's not everyone. The problem is you cannot predict the families and the child where it clearly is useful from the ones where it's just not really useful. There's no magical formula. But I always discuss the potential side effects. Strattera is useful, but takes longer to work and probably is less effective. But it is a drug of interest. Interestingly, this drug was actually manufactured by the drug companies as an anti-anxiety drug, but they realised it actually helps ADHD.
Got him.
And then obviously this sort of comes up, the stimulants is this an addictive drug, and people have obviously looked into this very carefully. The conclusion is no, but there is a connection between ADHD and addiction. And that is simply that you think about this, if you've got ADHD, you have a bit of an impulse control problem, you sort of act before you think, you are prone to risk-taking behaviour. So it's a complex relationship, and I don't suggest I have all the answers. And then there are other anxiety symptoms that affect some individuals, and then this symptom is an interesting one as well, this sort of rage or anger. Most people don't have this symptom, but maybe 10 or 15%. They're sort of very combustible. Sometimes it's an emotional anger, and sometimes it's just an anger. And I sometimes ask that question. I actually ask the kids and say, "Do you think is it an upset kind of anger, or is it just an angry anger?" And the kids often sort of know what I'm saying, and I think the families often know what I'm saying. But this sort of, again, this is just a control thing. It's emotional control. So we all get angry, we all get stressed, and we all get anxious. You just imagine if you're, people who don't have Tourette's, if you imagine your ability to control that anger was impaired, you can just imagine things can get pretty high pretty quickly, and that's sort of what happens. And then, as Adam made a very important point, mood is an important thing. Mood is connected with anxiety, mood is connected with OCD.
They are my
Okay? So, it's important to screen for that. Again, it's a very important thing. Again, as a group, one thing we can do is lobby for mental health, okay? The stigma of mental health still remains, but we're getting better. Okay? I'm a neurologist, and every time there's a mental health story on the news, I'm there. I want to know about it, because I realise this is so important. Emotional well-being is possibly the biggest threat to humanity. So we've got to prioritise it, and we've got to tell people, the B, how important it is. Oh, thank you. So the other thing is, yes, some kids have neurodevelopmental disorders, like autism, and sometimes the high-functioning autistic kids, we have not been diagnosed, and you see them, and you just pick up some clues, some social cues that makes you realise that there may be another neurodevelopmental disorder. So this is a very important thing that we sometimes, particularly the high-functioning kids with normal intellect, this can be often very delayed diagnosis.
Wow.
And then other sensory and learning things are, usually most people, learning is fine. But there's a small group who have learning problems. And then sensory symptoms. These are the symptoms, the kids with, we've noticed this for a while, people with Tourette, they just, a feeling that's on their skin, clothes, tags, feeling of clothes on their legs and their skin, but also loud noises, busy places. So these are all called sensory symptoms. And Nikki, there's Nikki, who's our occupational therapist. we've known about sensory symptoms in autism for a long time. And she's done a study in Tourette with people at our clinic, and we did 102 patients with tics and compared them with 60 patients who didn't have any, who were healthy, if you like. And then what we noticed, these are the sensory, this is the sensory score, this is the healthy, these are the autistic patients with tics, and these are the patients without autism who have tics. And you can see sensory symptoms are clearly elevated. And this is actually the first time this has actually been done, this work. We haven't published this work yet. But so sensory symptoms are elevated in kids with tics, as they are in kids with autism. The other thing we noticed was that emotional regulation score was elevated in the kids with tics, higher with the autistic kids, and much higher than in the healthy kids. And importantly, we think the emotional regulation correlates with the sensory. So the more sensory symptoms you have, the more likely you have emotional regulation symptoms. You can see there is a line. So in other words, the more sensory, the more emotional regulation. And really that's what we were seeing clinically, and you can see in 100 patients that seems to play out. This is important therapeutically because maybe there's a target there, therapeutic target to deal with the sensory symptoms, which is probably occupational therapy. So what is clear to me, having been working in Tourette with Tourette kids for about 20 years, and every clinic I do, all of the patients are different. There's no such thing as a normal or typical or whatever. Everyone's a little bit different. Everyone's got a different array of tics, a different comorbidity, a different impairment. And so sometimes about 15% have just Tourette's. Much more commonly they have Tourette, OCD or ADHD. And then sometimes they have other neurodevelopmental disorders like autistic spectrum disorder. The good news is there's lots of hope to our understanding. There's loads of people around the world doing research, trying to improve our understanding and knowledge. Clinical features, genomics, treatment, microbiome, people ask me about that a lot. It's very interesting in how our gut interacts with our brain. This is going to be a big story. I'm a neurologist, so I don't know much about it. Every time someone says, what about doing some microbiome research? I say, yeah, that would be really good, but I just don't want to do with pain. And alternative stuff, very respectful of that. And this is my sort of last slide. So I think I've covered all that. So, tics are just telling us something. We need to look more broadly than that for all this comorbidity. Education, empowering, and lobbying, influencing, role models, very important. And then medication is not necessary, but when it is, it does have a role. So I realise it's nearly midday. How are we doing for time? I'm happy to take any questions.
Yeah, we've got a few. Just trying to get this microphone. What's Susan feeling blue? Fuck it.
Okay, I've got a couple from people that were live streamed, so I'll just ask those first, and while I'm asking those, perhaps if anyone else has questions, they can think about them. A couple were texted through. This one is quite long, but it is. Thank you for talking about the immunology link. Could we ask about a link between TS and Ehlers-Danlos syndrome, EDS? It's been diagnosed a lot globally due to the high prevalence in people with EDS and TS. I'm really appreciating the conference. So, do you know much about that?
Sadly, look, someone else has asked me about that, and I'm afraid I don't know. I must say I've not actually seen. I think I've seen some people with. So Ehlers-Danlos is a sort of collagen disorder, hyperextensibility. I think I've seen maybe 1 or 2 patients who have both Tourette and Ehlers-Danlos, but not many. So look, I'm afraid I don't know.
That's fine. The second one, you actually touched on this in one of the early slides where the question says, I've noticed that there are many young people aged around 15 who are getting severe sudden occurrence in TS. Is this a new thing or something you're seeing more of? Why is this happening?
So we get referred, I think they are the minority. I see a lot of if you like, normal Tourette, whatever that is. And I've told you I'm not sure what that is, but within the spectrum of conventional, if you like, Tourette syndrome. But there were a group who sort of present after the age of 10 with sudden explosive tics. And I think I know they exist, and I see them, and I know this is real, but they are what we would call atypical. And I think you sort of know what is within the normal typical, and you know what is atypical. And this is important because you can sort of say, okay, if it's atypical, then we need to think about driving forces. So what else might be going on here? Is it a medical problem? Is it an infection? Is it a stress? Is it something else? So those are the patients that we ask each other, the clinicians. We often, videos are so important. You should saw it here both educationally, but also clinically. My phone is an important diagnostic tool, and the videos that families send me, I look at it and go, I think that looks obsessive compulsive, or I think that. So, we see these kids, we think about those questions about why is this happening, and try to see if there's a trigger or a precipitant. Is it happening more? I don't know. I can't really tell.
Anyone in the audience? Beaky bit.
Use a different one. I think that's what
Are you an onion?
One I'd like to ask about is freezing type esophageal muscle cesarean. My son's having one right now. He can't move a muscle except his eyes or his mouth. He comes and goes. We have not come across of any. Is that often associated with TS, or is it associated even with the Ehlers-Danlos?
I'm not sure about Ehlers-Danlos, but I've seen it with OCD, and again, I don't know you guys in detail, but so there was a little one, a 3-year-old that we got asked to see, and this is what we saw videos of this, and then she was walking along, and then she just stopped. And blink a few times. I'm doing this for effect now. And then she'd carry on. I was just enjoying the attention. And then she'd carry on walking. And so, we thought, oh, is it a seizure? She had an EEG. She got, and my fellow said, so find out, ask about the parents whether they have any problems, and ask the kid if she's having any worry thoughts or any thoughts. So Dad, as it turned out, has OCD, and the kid, when we asked the kid, and she's 3, and she's bright as a button, and she just says, I have a thought, and I have to do the thought right, and when I've done the thought right, I can carry on walking. We went, right. It's amazing. He's like, wow, this kid's brilliant. She's going to be a CEO. So is it a thought, like a freezing thought? I don't want to turn into a consultation, but I suppose you've got to think, is it a thought thing? Right, an hour and a half is pretty long. So it's a bit long for thought. Clearly needs investigating. I'm not doing very well so far this question. So far I don't know and I don't know. Ask me an easy one. Sorry? Yeah. Yeah.
During gestation, what about if they develop an autoimmune disease later?
Well, clearly we don't have the answer to that excellent question. But usually if you develop an autoimmune disorder, the prodrome, or the build-up to this, has often been occurring for a decade. So sometimes you're predisposed to having an autoimmune condition, and it often runs in families. And so people who have rheumatoid arthritis, for example, often the thinking is that they get an injury to a joint, and the trauma of the joint then initiates an immune reaction that then takes years or even a decade to develop into an autoimmune disease. Okay, so often there is a long build-up to this. I think all you can say is, if the patient is diagnosed with an autoimmune disease 10 years after the birth of the child, all you can say is there is a predisposition to immune issues.
Yeah, I just thought I'd ask, because a lot of it's about what happens during gestation, during pregnancies, and that connects a lot with a lot of people when they come
Yeah.
So you could even 10 years later.
Yeah, that's a good question. So this is a theory called maternal immune activation. And actually, if you type that into Google or you type that into PubMed, which is this medical thing, you'll get thousands of, so there's loads of animal models or other examples that this is a possible contributor. It's not proven. Don't make it. I'm not saying this is a proven link. This is a theoretical link. It's something that we see in our clinic. You see so many mothers that have psoriasis or Hashimoto thyroid disease. And you sort of, after a while, you sort of say, oh, we need to do some research on this and sort of try to unpick it. And we wonder whether this is connected to that sort of the PANDAS theory. Maybe this is that kind of link. Because I haven't talked about PANDAS and PANDAS. I believe there's a group that get this acute onset. I see this. And they get this very odd infection-provoked cause. But that doesn't mean it's an autoimmune disease. But there may be some infection linkage or immune linkage, and that's my thinking about it now. And I don't actually know what PANDAS and PANDAS is, to be honest with you.
What was that one again? Was it maternal immune
Activation.
Okay.
Yeah. It's a sort of theory, but there's lots of examples of this.
Over here,
Carol, did you have a question? You were waiting.
I was just puberty.
puberty. I've got hormones.
So in regards to worsening of symptoms.
Yes, so the question is puberty in relationship to worsening of symptoms. I get asked about that a lot, and actually most of the kids I see from 7 to 16 or whatever, the course, they don't seem to have more puberty-related issues than any other pubertal adolescent. Although I'm not 100% sure in my mind what normal adolescence is, but actually the 10 to 12, I do believe that the 10 to 12 is the genuine tick peak. And actually the kids who are 13, 14, 15, other than being normal adolescents, they seem okay. So I often am generally reassured. It's usually the underlying conditions themselves, these emotional, untreated emotional symptoms, untreated attention deficit, are usually the bigger predictors of function than puberty per se. People could contradict me at this point, but
I know it's not an autoimmune situation, but things like that.
Preeclampsia is very, very interesting. It's a complicated immunological response. So basically, pregnancy is an amazing thing. So essentially, what's happening is you've got a foreign object in you. Okay, the body's natural response is to reject foreign objects, foreign things. So what happens in pregnancy is you become immune suppressed. Our human evolution has created a form of immunological suppression to tolerate the fetus, and preeclampsia is a failure of that immune tolerance. So in theory, what you're suggesting, you're asking a brilliant research question, but it's a research question. Some people are interested in this, actually preeclampsia and autism, not necessarily into Tourette, but you're asking a fantastic question. In the same way, what's fascinating, another analogy, not the same, mothers who have untreated asthma, the children have worse, more severe early onset asthma, and it's beyond genetics. This is about the immune environment. So what it's saying is, if you're prone to something like asthma, and then you have an added stress, such as an inflammatory environment, because asthma is an inflammatory lung disease, it may make it worse. And the theory of our work is that might be happening. It may be an exacerbator of a problem.
Sorry, if a patient was to go through numerous SSRIs and none of them were working to treat anxiety and depression, just negative side effects, or is there any other option to successfully treat depression and anxiety?
Look, it's a great question because sometimes conventional stuff doesn't work, and sometimes you just got to say, I'm going to call it, and sometimes the child, the family, and the clinicians agree that, you can keep going. There's always another drug. There's probably 20 SSRIs. And in theory, there may be one that may work. or you step it up to the the bigger stuff. Yeah. So like quetiapine, Seroquel,
Yeah, sure.
is a very good anti-anxiety med, but it is an antipsychotic.
Yeah.
But when you need it, some kids, it does work, but it's a big drug. So look, sometimes you just stop because you've had enough, and actually the process of it is exhausting and not pleasant. So I think it's important, you just have this conversation, and if you try a drug and it's a negative experience, you're going to be a bit negative about future drugs, aren't you? I mean, that's human, that's natural. So it's a complicated therapeutic decision making.
You just got to keep trying to find the right one.
Within reason. Yeah, and it depends about how bad the problem is, and your coping strategies, and you are a model of success. And despite drug failure, yeah. So there you go. And again, it comes back to every patient's different, every situation's different, every family will be different, family perceptions. I will in a minute. Family perceptions and family expectations, and where the families come from. Some families are very anti-medicine, and I sort of respect that. Giving a medicine to a young child, it's a big deal. Yeah. So, but some families come to the conclusion that we have to try it. We've come to this point.
Okay, we've got two more questions because I know that Russell has to go here and then Scott.
Right.
Oh!
So, I've got cochlearia, and there are occasions, it doesn't happen very often, but there are times when I'm in a situation where people who are around me don't believe that I've got cochlearia, and they'll start something, shit, fuck off, they'll start something. And when that happens, I get very stressed, and it's sort of like a flight or fight sort of response to me that I get a couple of shit, fuck off, because it's a lot worse than it should be. And I might even start grabbing objects and throwing things. And these little tics, they're not anger that I would describe it. It's purely this sort of response to someone sort of not believing me and putting me in this difficult situation. And I often read about shit from threats and anger or threats and I never see any actual description of what I personally experienced, which may look like rape. I mean, I've had the police call me many times, even by doctors who didn't understand that I have cochlearia. Shit, fuck. So I feel like it needs to be written somewhere from a medical professional perspective that this situation can happen, so that I have a piece of paper that I can show. If one day, I mean, I'm imagining the worst, that if one day I get arrested and the police don't believe me and I end up in court for being a public disturbance or for whatever, shit, that I can show this paper to say, I'm not an emotionally disturbed person. Fuck off.
There was a brilliant description, and really, you've just informed us all. And the truth is, better than me, in truth, because, and what you explain makes good sense to me. And we know that tics and stress have a negative relationship. We know that, and you're describing a form of that, and Adam described that, about that, leaving the classroom and having that opportunity. So, the tics are bad, I'm just going to have a pass here, get out, move around, be on your own, have a move about, get some tics out. So you're having strategies to know that when you're escalating into that phase, try to remove yourself from that environment, be it a classroom or surrounded by some people, because you're escalating into a place that is going to get worse, perhaps.
I do have sort of ways of dealing with it. I mean, there are times, it's quite rare, but there are times when I'm sort of in a corner, I can't easily get out, and all these things are going on. But what I'm sort of more asking about is for someone to actually write.
Yeah.
I can jump in.
Try to Google it, you won't find it.
But maybe it should be, I think what you're saying resonates with someone like me, and it would resonate with Paminda Sachdev, and it would resonate with Valsa Epa, and it would resonate with people who are used to saying enough people with Tourette syndrome to know that what you're saying sort of resonates. So the opportunities is either document that on the Tourette syndrome website, sort of, a patient experience, or, an association you have noticed. Or, the way publications work is you try to put together a group of individuals reporting the same kind of thing to try to then report. So, if it doesn't exist, then yeah, probably someone should write about it, either social media, websites, professional websites, support websites, or in the publication material.
And just on that topic of if you had something to say, if you're, pulled up by the police or something, the TSAA has identification cards for people with Tourette's available for members. And we've got them at the back. There are generic ones, but there are also ones that we give that you must be a member and they're numbered. So if the police want to check with us, they're verified, so that you can have that. And a past TSAA president is a very high New South Wales police officer, so we have a direct line to for support. I have his card in my wallet. So, and he's had that experience with some other people with coprolalia in the past. So we've got to move on. We've got Scott over here.
I'm a bit confused. Precocious puberty. My 11-year-old is full on into puberty, like full on, and in a big way, and he tells everybody. But the research says that it's potentially the risperidone, or it's potentially just having ADHD, or it's potentially a whole range of stuff, and I'm really confused.
I involve our endocrinologists sometimes. This is not, I'm a neurologist. Puberty, I try. It's a bit like poo. I try to sort of. I'm a neurologist. But look, it's an important issue, and I suspect that predictors of precocious puberty may be a family history of that, and if there isn't a family history of that, then you probably just need to see an endocrinologist to sort of try to unpick it about what might be driving it, and then whether it needs to be slowed down.
No ketchup.
Thank you. I know there's more questions, but I'm sorry, we're really over time. And
Hey.
okay.
You can ask me now. I'll stick around for 10 minutes.
Yeah.